Marcus believed he was a danger to his own son, not because anyone told him so, not because he had done anything, but because of a thought, a single, uninvited thought, that arrived one afternoon while he was holding his 8-month-old over the kitchen sink rinsing formula from a bottle. The thought was vivid, it was specific, and the moment it appeared, Marcus set the baby down on the floor and walked to the far side of the room and did not go back. His wife asked what was wrong. He said nothing. He said he was tired. He stood with his back against the wall and waited for the thought to leave, the way you wait for a cramp to pass. But it didn't leave. It came back the next morning, and the morning after that. And for the next 3 years, Marcus would organize his entire life around a thought he never told anyone about. A thought he was certain made him a monster, while appearing, to everyone who knew him, to be completely fine. Obsessive-compulsive disorder is commonly understood through its most visible presentations. The person who checks the stove 17 times before leaving the house, or who washes their hands until the skin cracks. These external rituals are compulsions, and they are the behaviors that tend to bring OCD to clinical attention. But there is a subtype of OCD in which the compulsions are almost entirely invisible. It is called purely obsessional OCD, or pure O. The name is somewhat misleading. People with pure O do perform compulsions, but those compulsions happen inside the mind. Rumination, mental reassurance seeking, reviewing memories for evidence, replaying events to confirm that nothing bad happened. From the outside, the person appears still. Inside, they are in constant motion. The defining feature of pure O is the intrusive thought, an unwanted, involuntary mental event that arrives without warning and carries content deeply contrary to the person's values and identity. These thoughts are clinically described as ego-dystonic, meaning they feel alien, repugnant, and fundamentally at odds with who the person believes themselves to be. They are not fantasies. They are not desires. Research consistently shows that people with violent or sexual intrusive thoughts are statistically among the least likely to act on them. The distress caused by the thought is itself the evidence of that. The neurological picture involves hyperactivity in the orbitofrontal cortex and the anterior cingulate, brain regions responsible for error detection and threat appraisal. In OCD, this system misfires. It flags a thought as a real threat, and then it demands a response. In pure O, that response is mental, checking, analyzing, seeking certainty, and it is never sufficient, because certainty is the one thing OCD cannot provide. Marcus had been living inside this system for 3 years before the word OCD was ever applied to him. Before the thought arrived, Marcus was the kind of person who noticed things. He was a secondary school English teacher in his early 30s who kept annotated paperbacks on every flat surface in his house, and who could remember the names of every student he had ever taught. His colleagues described him as conscientious to a fault. He graded papers on Friday evenings when other teachers were at the pub. He sent follow-up emails after parent conferences. He worried, in a general and productive way, about whether he was doing enough. For his students, for his wife, for the world. His wife, Priya, was a hospital administrator. They had met at a mutual friend's wedding and spent the reception arguing pleasantly about a novel they had both read. They were good together in the way that people who take things seriously tend to be good together. When their son Eli was born, Marcus took 2 months of shared parental leave. He learned to swaddle. He learned the specific pitch of each type of cry. He was, by every observable measure, a devoted and gentle father. This is the context that matters, not because it makes what happened more dramatic, but because it explains why the thought, when it came, was so catastrophic to him. Marcus had spent his entire adult life being someone who cared. The idea that his own mind might contain something that contradicted, that was not just frightening, it was annihilating. The thought that appeared at the kitchen sink was intrusive and violent in nature, involving harm to his infant son. Marcus would not repeat it to a clinician for another 18 months. In the immediate aftermath, he did what most people in that situation do. He tried to push it away. He told himself it was a fluke, a misfiring synapse, proof of nothing. For about a week, that strategy seemed to work. Then the thought returned while he was giving Eli a bath, then again while carrying him down the stairs. Each recurrence was accompanied by what Marcus would later describe as a wave, a full-body surge of revulsion and dread that would crest and slowly, imperfectly recede. He began to avoid situations in which he was alone with Eli near anything he perceived as a hazard. He told Priya he was anxious about accidents, a reasonable enough concern for a new parent, and she accepted this without question. He began running mental inventories of his behavior throughout each day. Had he done anything that could be interpreted as dangerous? Had he thought something that might mean he was dangerous? He reviewed his interactions with Eli the way you review a document for errors, systematically, exhaustively, looking for something that wasn't there. He found nothing. The absence of evidence did not reassure him. OCD does not accept acquittals. What Marcus did not know, what almost no one who experiences intrusive thoughts of this kind knows, is that this response is almost universal. Studies suggest that over 90% of the general population experiences unwanted intrusive thoughts, including thoughts involving harm. What differentiates OCD is not the content of the thought. It is the weight assigned to it, the interpretation, the belief that having the thought means something terrible about who you are. By the time Eli was 14 months old, Marcus had restructured his life around the thoughts in ways that were increasingly difficult to conceal. He rarely put Eli to bed alone. He had quietly removed a set of kitchen knives to the back of a high cabinet, not because he planned anything, but because their presence felt unbearable. He had stopped reading the news after a story about child harm triggered a cascade of intrusive imagery that lasted with varying intensity for 11 days. He was not sleeping. He was spending 3 to 4 hours each night in a state of internal interrogation, running through the day's events, analyzing each moment he had spent near his son, searching for reassurance that he was safe to be around. He was teaching full days on 4 hours of sleep and grading papers at midnight and presenting to his students and his colleagues a version of himself that was fully functional. Priya noticed the distance. She assumed it was the adjustment to parenthood, to sleep deprivation, to the quiet grief that sometimes follows a life change even when the change is wanted. She asked him twice if he was okay. He said yes. The closest Marcus came to disclosing what was happening was an evening in the autumn of the second year, when he sat down at his laptop and searched the phrase, "Can you have violent thoughts and not be dangerous?" He read for 2 hours. He found forum posts from people describing experiences almost identical to his own. He found the term pure O. He closed the laptop. He did not search again for 4 months. The barrier was not ignorance, it was shame. To say the words aloud, to tell Priya or a doctor or anyone, felt equivalent to confession. He was not confessing because there was nothing to confess, but the thought had convinced him otherwise, and the conviction was total. What was happening to Marcus has a name in the clinical literature: thought-action fusion. It is the cognitive distortion, extremely common in OCD, in which having a thought is experienced as morally equivalent to performing the action. If I think it, I might do it. If I think it, I am the kind of person who could do it. Both propositions feel self-evidently true to the person experiencing them, and both are clinically false. The brain's threat detection system, centered on the amygdala and modulated by the orbitofrontal cortex, does not distinguish between a genuine threat and a thought about a threat. When the intrusive thought arrives, the body responds with the same physiological signature as real danger: elevated heart rate, cortisol release, heightened attention. This is why suppression never works. The research on thought suppression, beginning with Daniel Wegner's famous white bear experiments, consistently shows that the harder you try not to think something, the more frequently and forcefully it returns. Every attempt Marcus made to push the thought away, every mental check, every reassurance-seeking search, every avoidance behavior was, neurologically speaking, confirming to his brain that the threat was real and required continued vigilance. The compulsions were feeding the obsessions. The standard treatment for OCD, including pure O, is exposure and response prevention, ERP. In ERP, the the patient is guided to confront the intrusive thought directly without performing the compulsive response. The goal is not to eliminate the thought. The goal is to change the relationship to the thought, to allow it to exist without treating it as a signal requiring action. This is, by any measure, a profoundly counterintuitive process. For someone like Marcus, it required sitting with the thought and doing nothing. And doing nothing, after 3 years of constant internal management, felt like the most dangerous thing in the world. Marcus disclosed to his GP in the 3rd year, during a routine appointment ostensibly about insomnia. He used the phrase intrusive thoughts. The GP referred him to a clinical psychologist with a background in anxiety disorders. In the intake session, Marcus described his experience for the first time, in full, to another person. The psychologist did not appear alarmed. She did not reach for a phone. She said quietly that what he was describing was a well-documented presentation of OCD, and that the content of the thoughts, the fact that they were so distressing to him, was itself clinically significant. People who want to harm others, she explained, do not typically spend 3 years in private anguish about it. Marcus cried, not because he was fixed, he was not fixed, but because the thing he had carried in isolation had been named by someone who was not frightened of it. He underwent 18 sessions of ERP over 6 months. The early sessions were difficult. He was asked to sit with the thoughts, to narrate them without neutralizing them, to practice doing so until the anxiety habituated, which, at first, it barely did. By the 4th month, the thoughts had not disappeared, but they had changed in texture. They arrived, and he could observe them without the wave. He went back to bathing Eli alone. He went back to bedtime stories. The recovery was not linear, and it was not complete. He still had weeks, sometimes longer, when the volume increased, but he had language now. He had a framework, and he was no longer managing it alone. Priya, when he told her, said she wished he had said something sooner. He said he had not known how. She said she knew. They left it there, which was enough. Pure O is, in a strange and precise way, a disorder that targets the conscience. The thoughts it generates are almost always aimed at what the person loves most, or values most deeply. Parents receive thoughts about their children. Devout people receive blasphemous thoughts. Gentle people receive violent ones. The mind does not produce these thoughts because it wants them. It produces them because it is searching, frantically and misfiringly, for the worst possible threat to guard against. What Marcus's case reveals is that the absence of visible symptoms is not the absence of suffering. Some of the most severe psychological distress is invisible, contained entirely within a person who is still showing up, still functioning, still terrified in perfect silence. The brain can build a prison with nothing but thought, and some people live inside it for years before anyone knows to look. If you like unsettling psychology, like and subscribe for a new diagnosis each week.